Welcome to our video for World Awareness Antimicrobial Resistance Week. Today we're focusing on bacterial meningitis. Join us as we raise awareness about this important health issue and explore how we can make a difference together.
Understanding bacterial meningitis, a serious threat to the brain. Bacterial meningitis is a severe infection. It affects the meninges, the protective membranes surrounding the brain and spinal cord. This infection causes inflammation. The inflammation can lead to brain damage, hearing loss, and even death. Bacterial meningitis is a medical emergency. It requires immediate medical attention. Bacterial meningitis can occur at any age. However, it is most common in infants, young children, and adolescents. Certain medical conditions, such as a weakened immune system, can increase the risk of infection. Early recognition and treatment are crucial. This is because bacterial meningitis can progress rapidly. Knowing the symptoms and seeking prompt medical care can make a life-saving difference. The journey of infection from respiratory tract to the nervous system. Bacterial meningitis often begins with a common respiratory infection. Bacteria or viruses that cause illnesses like the flu, colds, or pneumonia can sometimes spread to the bloodstream. From there, they can travel to the meninges. There are many pathogens related to bacterial meningitis, directly or indirectly, according to the health state of patients and their immune system efficiency, and also their age. The most frequently implicated bacteria beyond the neonatal age are Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae, serotype B and non-typable strains. The most likely causative bacteria may differ across age groups. For example, meningitis due to Haemophilus influenzae mainly affects children. And in patients with immune system deficiencies, for example, increased risk of Listeria monocytogenes. Increased risk of meningitis caused by encapsulated bacteria such as Neisseria meningitidis and Streptococcus pneumoniae in patients with asplenia or hyperspleenia. Tuberculous meningitis should also be considered in the differential diagnosis in patients living in or coming from areas where TB is endemic, especially if the onset of disease is not acute. For further information about pathogens, please take a look at the attached reference. Recognizing the signs and symptoms in adults and children is crucial for timely treatment and better outcomes. To recognize meningitis in adults, look for sudden symptoms that may appear within 48 hours. These can include a high fever of 38 degrees Celsius or more, severe headache, confusion or changes in mental state, and neck stiffness. These symptoms don't always appear together, but any combination of them could mean meningitis and requires quick action. Being aware of these early signs can make a critical difference. In infants, the symptoms may be more subtle and harder to detect. They can include irritability, poor feeding, a high-pitched cry, and a bulging fontanelle, which is the soft spot on the top of the head. Parents should be vigilant and consult a healthcare professional if they notice these signs. A hemorrhagic rash may also be present, especially in cases of meningitis caused by Neisseria meningitidis, although such a rash is not specific for meningococcal infection. Notably with Streptococcus pneumoniae, understanding the full range of symptoms and their progression is key to ensuring timely and effective medical intervention for both adults and children. Diagnosis: unveiling the silent invader. Diagnosing bacterial meningitis requires a combination of a physical examination and laboratory tests. This process is crucial because the symptoms of bacterial meningitis can often resemble those of other illnesses, making it a challenging condition to identify without thorough investigation. In the presence of compatible signs and symptoms, a definitive diagnosis of bacterial meningitis requires examination of cerebrospinal fluid. A lumbar puncture should be done before starting antibiotic treatment. However, doing a lumbar puncture should never delay giving antibiotic treatment when bacterial meningitis is suspected. If available, at least blood cultures should be taken before starting treatment. CSF findings suggestive of bacterial etiology: high opening pressure, normal range 80 to 200 mmHg or 8 to 20 centimeters H2O, turbid aspect, elevated white blood cell count, often several hundred to several thousand, WBC-MM3, elevated percent of neutrophils, 80%, elevated protein, 45 mg/dL or 0.45 gl, CSF serum glucose ratio 0. For imaging tests, Connecticut scanning should never delay the start of antibiotic treatment. If available, imaging is indicated in patients with focal neurological signs, decreased level of consciousness or coma, or a history of central nervous system disease or recent onset of seizures for more than 1 week, or severe immunosuppression. Recognizing bacterial meningitis early can save lives. If you notice any warning signs, seek medical help immediately. Early detection makes a critical difference. The race against time urgent treatment with antibiotics. Bacterial meningitis is a medical emergency that requires immediate treatment with antibiotics. The type of antibiotic used will depend on the specific bacteria causing the infection. The choice of empiric antibiotic treatment should take into account the age of the patient, presence of immunosuppression, and local prevalence of Streptococcus pneumoniae isolates resistant to third-generation cephalosporins. The patient risk of Listeria meningitis should also be taken into account, for example, pregnant women, patients who are immunocompromised, or patients 50 years of age, because ceftriaxone and cefotaxime do not cover this pathogen, and ampicillin should be used in these cases. As a general rule, empiric treatment in children other than neonates and in adults should always cover all three of the main causative pathogens like Haemophilus influenzae, Neisseria meningitis, and Streptococcus pneumoniae. If a pathogen is isolated and its susceptibilities are known, antibiotics should be reviewed and modified accordingly. When no pathogen is identified, the duration of antibiotic treatment should be guided by available laboratory results and clinical response. Step-down to oral treatment is less commonly used in meningitis management, where the treatment is mainly parenteral where possible to maximize penetration into the cerebrospinal fluid. Reducing inflammation. The role of corticosteroids. Corticosteroids, such as dexamethasone, are often given in conjunction with antibiotics to reduce inflammation in the brain and spinal cord. In cases of meningitis, is to reduce the inflammatory response and the risk of neurological sequelae, for example, hearing loss and death. Steroids are not recommended in neonatal meningitis. The decision to use corticosteroids should be made on a case-by-case basis, taking into account the individual's age, overall health, and the severity of the infection. Post-exposure antibiotic prophylaxis should be considered in outside of the African meningitis belt for all close contacts within the household. E.g. Egypt, ciprofloxacin, usually 500 mg oral single dose, is the antibiotic of choice, and ceftriaxone can be used as an alternative, usually 250 mg intramuscular single dose in adults and 125 mg intramuscular single dose in children. Primary prevention of bacterial meningitis relies on vaccination and antibiotic prophylaxis for close contacts of cases. Vaccination is a successful intervention to prevent bacterial meningitis. Available vaccines are active against meningococcal, pneumococcal, and Haemophilus influenzae type B disease. Vaccines are never 100% effective, and they do not protect against all strains of a bacterial pathogen. Thank you for being with us. This is brought to you by Exception Team, Faculty of Pharmacy, Egyptian-Russian University, under the supervision of the Microbiology and Immunology Department.